Paul, maybe you could talk a little bit about the advances that have occurred in chemotherapy, or as we term it, systemic therapies. Virtually every patient with pancreas cancer who is treatable will end up seeing a medical oncologist. Hopefully they're able to see someone like you who has a vast experience with this disease, but oftentimes that may not be possible. I know that you spend probably a third of your time, if not more, helping oncologists from around the country who are less experienced, giving them little helpful hints and suggestions on how to treat patients. Not every pancreas cancer patient will have an operation. Not everyone will necessarily get radiation therapy, but probably everyone will get chemotherapy.
Well, the chemotherapy for pancreas cancer has improved significantly over the last few years. The principles and the regimens that are used are initially developed in more advanced metastatic disease and then extrapolated to earlier stage disease once they're deemed to be effective. Currently, there are basically two default regimens, and sometimes you might choose one rather than another, depending on the individual patient, what you feel that they could tolerate. Our goal is to try to effectively shrink the tumor and cause minimum toxicity if we can. All of these drugs are potent. They have potentially significant side effects, and we really try to minimize that without compromising the effectiveness of the treatment. The goal of the chemotherapy in the early stage disease is really twofold. One, as previously mentioned, is to try to shrink the tumor to facilitate, along with the radiation, facilitate surgical resection. But probably even of greater importance is the fact that we know from experience that these are tumors that often spread early, and we can treat the disease that we see with local modalities, but the concern is that there is a very high risk of recurrence, either in the liver or elsewhere in the abdomen or other places. And one of the important roles of early systemic chemotherapy is to try to eradicate that microscopic metastatic disease that we don't appreciate on the imaging.
Certainly one of our underlying biases is that most patients at the time of diagnosis, and I think Susan alluded to this, have microscopic spread of the cancer to other parts of the body, even though we can't see it on one of Parag's excellent CT scans, whether it be imaging of the entire chest, abdomen, pelvis, etc. And therefore, the hypothesis that giving the chemotherapy earlier in the treatment of microscopic cancer cells may be more effective than giving it later. Another way to state that is that when the cancer comes back, it's not due to the abnormality we can see in the pancreas on the CT scan. It's actually due to the disease we can't see. Do you find that some patients have difficulty, and in fact doctors have difficulty understanding that? And what is your advice to them?
Yeah, well, I think, and you've been one of the pioneers of promoting neoadjuvant treatment, that is chemotherapy and radiation prior to surgery rather than after surgery. And certainly one of the goals is to try to eradicate microscopic metastatic disease that has really plagued us from the beginning. And the recurrence rates with surgery, even though surgery is absolutely necessary to cure the disease, it's not sufficient. And I think radiation certainly has an important role to reduce the risk of local recurrence. And I think that as our chemotherapy gets better, and we are making progress, unfortunately there have been baby steps, but they, one step after another at least moves us forward. And as the systemic treatment gets better, hopefully we can have a bigger dent and prevent recurrence at distant sites or metastatic disease.
Great. Susan, maybe a couple words on what a clinical trial is and why a treatment would be part of a clinical trial, especially for those patients who may be watching this video who have certainly heard the term clinical trial but are unclear as to what that actually means, and maybe a little bit about the current clinical trial for resectable pancreas cancer here, and the clinical trial that is going to the IRB probably this week for more advanced disease.
So just as you mentioned, Dr. Evans, oftentimes we think of medicine as both an art and a science, and the science aspect in terms of oncology is testing hypotheses with a clinical trial. So oftentimes if you just do what has been done for many decades, you will not see any advancements, and we see that very clearly in pancreas cancer, where, you know, over the past 30 years there's really been no marked improvement in survival. And so the idea to test a new way of treatment and then see if that is actually different from how we've always standardly practiced is very important. I think it's a cornerstone of oncology. So with regard to clinical trials, we have a current clinical trial open for resectable pancreas cancer. This is in collaboration with investigators at MIT who have done really some seminal work looking at cancer stem cells, and utilizes a very tolerable and already FDA-approved drug in combination with standard chemoradiation in the neoadjuvant setting. And in those patients, we're looking to see if there is a drug response in the surgical specimen. That trial actually has really accrued at a phenomenal pace and probably will be closed shortly. On the heels of that, we do have another clinical trial that is going to be open in the next couple months, which focuses on both resectable and borderline resectable patients. And in that trial, we actually utilize molecular profiling to really tailor the chemotherapy specifically to the characteristics of each patient's individual tumor. And then what is novel about that trial is that we're utilizing response elements, so how much your tumor marker responds, what the radiographic response is, to guide how much therapy you get, so that if you have a robust response, you get a very good chemotherapy. If you're not having a great response, then your chemotherapy will be changed, hopefully to a more effective therapy.
Great, really exciting. That development of definitions of response is something completely novel and unique to this trial. Beth, maybe in our last few minutes, you can comment a little bit about the different techniques of radiation therapy, because so many people are confused about all the terms, IMRT, SBRT, gamma knife, nano knife. I mean, what is truth here?
Well, radiation is, you know, in some regards, a very technical art and science. Radiation has to be delivered carefully in the upper abdomen. This is a busy section of real estate. We have the pancreas and the tumor within the pancreas, but we also have the stomach, the duodenum, small bowel, kidneys, liver, spinal cord. So as radiation oncologists, we have to be able to navigate that area and get the radiation where it needs to go and keep it from getting to those organs that are sensitive to radiation and could potentially be damaged. So we do that using imaging. We use the wonderful CT and MR images that our radiologists provide to us, and we also get those in our department through what's called a simulation, where you'll come to our department, have an IV placed, drink some dye, we'll scan you in the radiation treatment position and use those images to create your radiation plan. We use both CT imaging and MR imaging for that. From those images, we locate the tumor, we want to give the dose there, we want to avoid the other organs, and we can deliver that radiation through different mechanisms of radiation, which Dr. Evans has alluded to. Probably the most common one now is IMRT, which is intensity modulated radiation therapy, where there's different intensities of the beam hitting the tumor versus touching those organs that live close by. Coupled with that is another acronym called IGRT, Image Guided Radiation Therapy, where every day before your radiation hits your body, a mini CAT scan is done confirming that the radiation's in the right place. And we do that currently with CT, but we'll be evolving into an MRI scan during your radiation with our new MR Linac. All of those things assure that the radiation is given very accurately, exactly where we need it, and it's allowed us to shrink the size of the radiation dose cloud so that it hits what it needs to hit, but doesn't hit a lot of those normal organs. That reduces side effects and late toxicities. and also allows us to increase the dose of radiation to tumors that are unresectable. There's another term called SBRT, stereotactic body radiation therapy, where instead of getting radiation over 5.5 to 6 weeks, you may have 5 treatments given over 1 or 2 weeks. This is used most commonly now in the locally advanced setting, but is beginning to come into our practice as a preoperative modality. The thought here is get the treatment done more quickly, and that dose that's given in 5 treatments may be more of an ablative dose or a bit harder on the cancer cells than what the 5.5 to 6 weeks is. So there's lots of interest in what we call fractionation in radiation. And many, many questions to answer yet as to the efficacy of one versus the other.
Great, thanks so much. Parag, maybe I can give you the final word. I mean, we've presented CT scans, MRI scans, et cetera, as all or none. In other words, the radiologists always know exactly what's going on. Certainly patients and family members who have struggled with pancreatic cancer know that occasionally there will be question marks on the CT scan. Is there an abnormality in the liver? Is there an abnormality in the lung? Might I have metastatic disease? Is it really localized to the pancreas? I think you have done incredible work in this area. I know that there's a manuscript that will soon be published on the issue of indeterminate spots in the liver. But maybe you can clarify this for the people who will be watching this video, because this is an area of tremendous anxiety for many patients.
I mean, for many patients, and I know that you see in clinics, a lot of anxiety hangs on the scan. I mean, we see that not just in pancreas, but any cancer in general, because the scan kind of demonstrates a lot. What does the scan show? And having friends and family with cancer as a patient and a family, I completely understand how patients feel with that as well. So it is. So as much as we try in radiology be objective as possible, what we are really doing with CT or MRI is really shooting X-rays through your body and then determining how different tissue types are in your body. So we sometimes see spots in the liver or in the lungs or in the bones. And same thing with MRI, we're jiggling water molecules inside of a magnet, and we're trying to infer what are these things that are abnormal. And our training has tried their best to show us, what is a metastatic lesion versus a benign thing. And there are a lot of benign things that show up in our body. I mean, we're very complex people. We walk around, we're all very unique. We have different things that go on inside of us, and we're all different. And so one of the challenges radiologists is try to determine which one of those things are metastatic versus non-metastatic. And there's a lot of overlap in the imaging appearance. You try your best, you get a CT, you may use an MRI to try to figure it out, or even a PET scan, or even sometimes ultrasound, and you kind of chasing your tail sometimes trying to figure out what some of these things are. But I think one of the things that we've decided to do, and the program has done well, is to be intellectually honest about it and calling these things that are very small, that are probably most likely going to be benign, just based on experience of most of the spots that we see in the liver are almost usually below less than 7 are almost always benign in the setting of a cancer, such as cysts or hemangioma. They're like pimples or zits on our skin. That's what they really are. We see them all the time. And so intellectually being honest and just calling those indeterminate, and then moving forward as a treatment plan and not perseverating on whether or not it's a metastatic lesion or not, but then just saying it's indeterminate and moving on with their treatment plan. Those patients typically get placed into the borderline resectable category and start that neoadjuvant therapy. And typically we can then follow up the scans. If these things are stable, they probably were just cysts or hemangioma. If they start growing in the middle of treatment, then it kind of confirms that maybe these were metastases. So time also helps us as well with these scans, where we use time to help us determine if these things are benign or malignant. But it is frustrating as a family and for a family and patients to hear about these spots. And I know a lot of people focus on the radiology report. So we're very cognizant, and we try our best working with the team and with our patients or reports for them to understand what we mean when we use these words and try to standardize that terminology.
Great, thank you. Well, I would like to conclude by certainly an acknowledgement of a few services and specialties that are not present today. As I mentioned earlier, our gastroenterologists are incredibly talented here. The cornerstone of our pancreatic cancer program is the ability to biopsy the tumor, which is performed with endoscopic ultrasound by our gastroenterologists, who are actually working now so that they couldn't be with us on this panel. And they also are incredibly talented at safely placing stents within bile ducts and occasionally within other parts of the gastrointestinal tract. The ability to do this safely and in a timely fashion is critically important to any patient with pancreas cancer. Also, the support of specialists in diabetes management, nutrition, and all of the infrastructure involved in guiding the patient through a complex medical center is just invaluable. Thank you all for joining, and necessary phone numbers, contact information will be provided at the end of this video. Thanks for watching, and thank all of you for participating.